In this lecture, we will go over MPGN pattern of glomerular injury. As you may know, there are many different patterns of glomerular injury, and behind each of them, there is really differential diagnosis and the list of different entities that go with those patterns. Some diseases may present with different patterns, meaning that, for example, lupus nephritis can come in different flavors. You can have membranous lupus nephritis or focal proliferative, diffuse proliferative, mesangial-proliferative, and so on. Hepatitis C can present either with MPGN pattern, or you can have membranous pattern of injury with hepatitis C, and so on. One of the biggest problems we face in kidney pathology is that once upon a time, we had only light microscopy and we knew very little about mechanisms of diseases, pathogenesis, and whatnot. And we didn't really use immunofluorescence and electron microscopy in those early stages to be able to further characterize these lesions in individual patients. So we started naming particular diseases by patterns of injury. So that's how we got stuck with the name of focal sclerosis, for example, in kids with steroid-resistant nephrotic syndrome. But now we know that there are all different kinds of focal sclerosis. Some of them can be genetic or due to obesity, metabolic syndrome, structural functional adaptations, and so on. You and I have focal sclerosis, and that really becomes very confusing when we try to distinguish between these different groups of patients. Membranous nephropathy is another example. As I said, you could have membranous lupus nephritis, but there are also other causes. Even, like in primary form, you have renal-limited autoimmunity against M-type phospholipase A2 receptor and so on. But when we named or came up with the name of membranous nephropathy, we really didn't know any of this, and we just looked at the light microscopy and said, oh, the membranes are thick. Let's call this membranous nephropathy. And it's similar with MPGN. It's another grotesque example of this confusing practice with terminology. Every textbook really describes MPGN as idiopathic and subclassifies it into types 1, 2, and 3. And the emphasis really in this classification is given to structural findings rather than the mechanisms and pathogenesis of the disease. So let's talk about MPGN. First of all, what is MPGN, and when do we say that the pattern of injury is MPGN? So when we see hypercellularity, capillary wall thickening, and lobular accentuation of the tuft, some people even call it lobular GN, and you see it here, this lobularity, a lot of hypercellularity, thickened basal membranes, and in some cases you can see very nice double contours. You also see endocapillary hypercellularity, mesangial hypercellularity, and on electron microscopy, this can be due to the presence of subendothelial deposits. And here you have, for example, this is original basal membrane here. This is a subendothelial deposit. This is a new basal membrane over here. And similar here, you have subendothelial deposit with two basal membranes on each side. So that is really your typical MPGN with the deposits. However, sometimes you don't actually really have deposits, and you have restructuring of the or remodeling of the capillary wall without deposition. So here, for example, you have original basal membrane here, and then you have this subendothelial widening, and your endothelium is actually over here, and you have cell interposition and different debris and subendothelial flocculent material deposit in there, but really no electron dense deposits. So when I think of MPGN pattern of injury, I really focus on what is depositing and whether we have deposits. So there are four groups of associated conditions. One is with immune complexes, and you will see polyclonal immunoglobulin depositing. The other is paraprotein deposition diseases, where you will see monoclonal immunoglobulins. Then the third category is complement regulatory protein abnormalities, where you have abnormalities in complement alternative complement pathway, and you will have complement deposition, thrombotic microangiopathies or endothelial cell injury that will have really no deposition. And we will talk about these categories as we go on. But as you could imagine from even what I just said, you really need immunofluorescence microscopy to tell you what is behind this pattern and what is depositing. So when you have immunofluorescence microscopy, you will figure out whether you have immunoglobulin deposits or C3 deposition without immunoglobulins, or you don't have deposits to begin with. So your differential diagnosis will really depend on that, and this is what you will see. So with immunoglobulin deposits, you either have, as I said, polyclonal deposition, and those would be either deposits of circulating immune complexes in chronic infections, autoimmune diseases, or you will have monoclonal deposition in paraprotein deposition diseases. If you have only C3 deposition, you think of complement pathway abnormalities, including dense deposit disease and C3 glomerulopathy. Or if you don't have deposits, you think of endothelial cell injury and thrombotic microangiopathies. As I mentioned, in immune complex diseases, you think of autoimmune processes, chronic infections, anything that can give you chronic or episodic antigenemia. So you see a list here, and it's really just an example of what that can be. Anything that can give you circulating immune complexes fits in that category. And you will see polyclonal deposition. So what you have here is the same glomerulus on different sections stained with different things, and I showed you only staining with the heavy chain of IgG, so gamma, kappa, and lambda light chains, and you see that this is polyclonal. By electron microscopy, you can actually see here a deposit, subendothelial deposit. This is original basal membrane, and this is a new basal membrane. The important thing to know here is that when you don't remove subendothelial deposit for whatever reason, either that your immune system is not really quick about like removing these deposits, or they're not really triggering enough inflammatory reaction to have them removed or something like that, you will end up with a deposit that's sitting there and interfering with attachment of the endothelium to the basal membrane. The endothelium has in mind that it wants to be on the inside of the capillary wall, so close to circulation. So it will not want to be under the deposit, but it will actually create a new basal membrane, and then you end up with duplication, and that's why you have MPGN pattern. If one of the light chains is missing, then you think of monoclonal deposition, and then your patient actually has a completely different problem. Now you think of processes that can give you clonal expansion, such as all sorts of lymphoproliferative diseases, myelomas and lymphomas and whatnot. So as you can tell, that's very different than if you had a patient with lupus or hepatitis B or C or whatnot. It's very important to understand that immunofluorescence will really help you categorize your patient in various groups here. Sometimes these deposits will have substructures, and usually paraproteins will tend to form these substructures, but they don't always have to be present. So again, you have to really do your immunofluorescence to further characterize the lesion. But here you have a paraprotein deposited. This is original basal membrane. This is a new basal membrane. And if you can imagine, if you stain this on light microscopy by PAS or silver stain, you will see this as a double contour. One membrane here, one here, and the deposit would not really stain. And this is here a podocyte on top. If your deposition is only of C3 or complement, then you think of complement pathway abnormalities. Um, Alternative pathway is regulated by different factors, factor H, I, and so on. And what happens is actually that alternative pathway gets sometimes triggered by bacteria or toxins and so on. And as it gets triggered, it gets into that positive feedback loop, and it gets amplified. The response gets amplified. Which is really important if you want to get rid of bacteria. But on a normal cell surface, like for example on the endothelium, you don't want that. You want to actually inhibit that activation, and that's why you have these factors that will put a brake on it. But if they are abnormal, if you have some genetic defect in these factors or acquired antibodies against these factors, then that inhibition will be problematic, and you will end up with excessive um, amplification of alternative pathway, and you may end up with C3 deposition in the glomeruli, or sometimes similar process can lead to endothelial cell injury, and you will end up with atypical HUS. It's not completely clear why in some patients with defect in factor H you will end up with C3 glomerulonephritis, and in others you may have endothelial cell injury and atypical HUS type of a picture, but it happens. So one of the forms of this alternative complement pathway problem is dense deposit disease. In the past, it was classified as MPGN type 2, but we know that this is not really an immune complex disease, but the complement deposition, and it's with this kind of like very dense deposits that are intramembranous, sometimes sausage-shaped or ribbon-like, and it's very important to remember these buzzwords for the board examination, but this is how it would approximately look like. Sometimes you may have just mesangial deposits, and it would look like immune complexes almost, but again, immunofluorescence will be very important to study these and to put them apart. Sometimes you will see classic subendothelial deposits, like for example here, and then we would call this glomerulonephritis C3 or C3 glomerulopathy rather than dense deposit disease. So again, it's just a morphology that will that will put apart dense deposit disease from C3 glomerulonephritis or C3 glomerulopathy, and that's not really important as much as understanding what's the mechanism of this deposition. In traditional classification of MPGN, what is recognized is that we have idiopathic forms and secondary forms, and the emphasis is given to this idiopathic forms, and then we went on to classify that into type 1, 2, and 3, and I will really be blunt and say right away here that this is really not important at all. Type 1 goes with subendothelial deposits. Type 2 is not even an immune complex disease, but it's a deposition of C3, as I already mentioned. And type 3 has these two different variants, Strife-Enders variant and Burkholder variant. I'll just mention them because they are present in textbooks, but again, they're not very important. By electron microscopy, when you see only subendothelial deposits, you will say it's MPGN type 1. If you see this kind of like intramembranous deposition, it would be type 2. And if you have these membrane defects, like for example here, you will call that Strife-Enders variant or type 3. And another one is Burkholder variant, where you have subepithelial deposits. So if you will, type 3 is really a subtype of type 1 that you would see by electron microscopy. And again, it's really not that important. What's important is really what's depositing, whether you have immunoglobulin or complement or no deposits, and then try to figure out what is depositing. I hope this clarifies things a little bit, and I really appreciate you joining me in this little lecture. I thank you very much for your attention.